Allogeneic hematopoietic stem cell transplantation, HSCT, is the only curative option for many hematological malignancies. However, the development of graft-versus-host-disease, GVHD, limits allogeneic HSCT success. Current understanding of the mechanism underlying acute GVHD. Acute GVHD is thought to primarily be caused by the recognition of self, or host, antigens by donor T cells. Tissue damage is a key component to initiate acute GVHD, and often begins prior to the introduction of the graft. This tissue injury is due to inflammation associated with the hematopoietic stem cell preparative regimen, but may also have occurred as part of the underlying disease, for example, hemophagocytic lymphohistiocytosis, or its treatment, for example, chemotherapy for hematologic malignancy. Myeloablative and total body irradiation-based regimens, associated with greater tissue inflammation, have been linked to higher rates of acute GVHD. Notably, the sites most affected by acute GVHD are also the sites of greatest tissue injury after hematopoietic stem cell transplantation: the skin, gastrointestinal tract, and liver. This tissue damage leads to the activation of antigen-presenting cells, APCs, through the release of inflammatory cytokines, TNF, IL-1, and others, pathogen-associated molecular patterns, PAMPs, danger-associated molecular patterns, DAMPs, and the increased expression of MHC antigens and co-stimulatory pathways. This initiates donor T cell activation that targets host antigens via host or donor antigen presentation via MHC to donor T cells, followed by T cell receptor engagement and co-stimulation in the established pro-inflammatory milieu. This process is augmented in the setting of antigen mismatch and increased T cell dose, but can occur even in matched transplants, due to the absence of host thymus selection by donor incoming T cells, and recognition of minor antigen differences. These activated T cells will undergo proliferation and differentiation, and produce more pro-inflammatory cytokines, PAMPs, and DAMPs, leading to an inflammatory cascade that results in the end organ damage, known as acute GVHD. Many risk factors for acute GVHD have been identified, and include increased HLA disparity, increased intensity of the conditioning regimen, female donors for male recipients, and decreased gut bacterial diversity. In summary, acute GVHD likely stems from tissue injury, inciting a pro-inflammatory milieu with host antigen presentation, T cell activation that includes many CD4 positive subsets, and a vicious cycle of T cell produced pro-inflammatory cytokines that induce ongoing tissue damage. Current understanding of the mechanism underlying chronic GVHD. The mechanisms underlying chronic GVHD remain incompletely understood. Since acute GVHD is a major risk factor for the development of chronic GVHD, there is an overlap in these drivers. These include tissue injury, T cell dose, and age of the donor and recipient, and withdrawal of immunosuppression. Tissue injury may be pre-existing, due to pre-transplant preparative regimens, such as in acute GVHD, or due to second insults, induced by later infections, and the impact on the microbiome, or local injury, for example, sun exposure. Similar to acute GVHD, tissue injury leads to the production of DAMPs, exposing previously dormant host antigens, that can engender alloimmunity. Higher T cell dose, HLA mismatch, and use of peripheral blood mobilized stem cells rather than marrow, are risk factors for both acute and chronic GVHD. This is likely due to the presence of higher numbers of ALA-reactive T cells in the product, and a greater likelihood of ALA reactivity due to mismatch. Increasing age of the donor and recipient also increases the likelihood of acute and chronic GVHD, which may be due to greater exposure to host antigens through increased age-related tissue impairment, and a more oligoclonal donor T cell populations, linked to decreased tolerance. Collectively, data support that chronic GVHD is a dysregulated immunity, often established early in the transplant process, through tissue destruction, alloantigen recognition, and a predominance of activating lymphocytes with few regulator cells, to curb the storm that culminates in chronic GVHD. Strategies to reduce acute and/or chronic GVHD. One of the most important factors in the prevention of GVHD is the selection of a donor. HLA identical matched siblings remains the gold standard for transplantation and is associated with the lowest rates of acute and chronic GVHD. There is ongoing debate over the next best option: unrelated, cord blood, or haploidentical donor. High-resolution HLA typing for unrelated donors is recommended to include HLA A, B, C, DRB1, and DPB1 loci, with HLA DQB1 and DRB3, 4, 5 optional. Matching at HLA A, B, C, and DRB1 should be prioritized, and non-permissive HLA DPB1 mismatches should be avoided due to its association with increased mortality. More recently, evidence has also suggested that certain HLA-B leader dimorphisms may impact outcomes, with better rates of GVHD and non-relapse mortality for those mismatched at the threonine leader (TT) genotype, compared to either the methionine genotypes (MM) or MT. In summary, both acute GVHD and chronic GVHD involve distinct pathological processes, highlighting the need for stage-specific treatment approaches. Whereas acute GVHD has strong inflammatory components, chronic GVHD displays more autoimmune and fibrotic features. Overall acute GVHD cascade. Initiation and maintenance of acute GVHD has been conceptualized into 4 phases, with feedback loops that self-sustain the process. Although the effect of the conditioning phase in acute GVHD is not necessary in many of the models, it activates APCs via tissue destruction and improve APC capacity. It also, through the release of gut bacteria, PAMPs, and chemokines, can activate cellular components of the innate immune system that can participate in direct tissue damage and contribute in cytokine storm. Following antigen presentation, a strong cytokine response is initiated, promoting greater antigen presentation and recruitment of T cells and innate immune cells, further contributing to the inflammatory cytokine milieu. Finally, the T cells, NK cells, macrophages, and pro-inflammatory cytokines will result in end organ damage, clinically recognized as acute GVHD in the skin, lung, gut, and liver. Critical factors in the development of chronic GVHD. The pathophysiology of chronic GVHD mostly revolves around the polarization of T helper cells to a T helper 2 cytokine phenotype, but there are some hallmarks that are unique to this syndrome. These include damage to the thymus, associated with the conditioning regimen, and more importantly, occurrence of acute GVHD earlier in the post-HSCT course, resulting in decreased negative selection of ALA-reactive CD4 positive T cells. T helper 2 cytokine pattern deviation, resulting in release of fibrogenic cytokines, such as IL-2, IL-10 and TGF-beta, macrophage activation, followed by tissue fibroblasts proliferations, and activation through the release of TGF-beta and PDGF from macrophages, lower Treg levels, and finally, dysregulation of B cells, leading to emergence of autoreactive B cells, and production of autoreactive antibodies. All these will result in autoimmune-like systemic syndrome, mostly associated with fibroproliferative changes that can occur in almost any organ and body, but primarily affecting oral and ocular mucosal surfaces, and the skin, lung, kidneys, liver, and gut.